A very good afternoon, everyone, and a warm welcome to our Facebook Live today on a very interesting topic, one that is surprisingly prevalent among Malaysians and definitely one that many of us would shy away from discussing. But we are going to discuss it today, and that is the topic of hemorrhoids. Allow me to first introduce myself. My name is Thomas Lai. I'm a pharmacist at Assunta Hospital, and I'll be your moderator today. Thank you for joining us today, and I hope you are safe and well wherever you are during this COVID-19 pandemic. It is an absolute pleasure to have with me today an esteemed and experienced speaker, doctor and surgeon, Mr. Jeyaratnam Kasipillai, Consultant General Surgeon at Assunta Hospital. Hailed from Kuala Lumpur, Mr. Jeya, as he is fondly known by his patients and colleagues, obtained his Bachelor of Medicine and Surgery, MBBS, from Mysore, India, and later earned his fellowship of the Royal Colleges of Surgeons, FRCS, from Edinburgh, UK in 1984. He is also a fellow of the prestigious International College of Surgeons since year 1991. Mr. Jeya has a vast amount of clinical experience under his belt, gained through his passionate practice in the field of medicine and surgery over the last 40 plus years in various institutions in Malaysia as well as abroad. To name a few, Hospital Kuala Lumpur, University Hospital, and Klang General Hospital. So here's a little reminder before I hand the next part of this session to our speaker. If you have any questions during this live stream, please feel free to type them into the comment box below this live stream. I'll bring the questions up during the Q&A session so that our speaker may answer them. And also, don't forget to like and share this live video with your friends and family so they too can join us in this session. Now, without further ado, I welcome Mr. Jeya to speak on the topic Haemorrhoids No More, Conservative Management and Surgical Approach. Please, Mr. Jeya.
Introduction, right? Today I'm going to talk on hemorrhoids no more, the conservative management and surgical approach. Some of you who may be listening to this may have heard me talk on this topic many times before. I've spoken it as common perianal conditions. Today I'm just going to talk about hemorrhoids. So without further ado, let's move to the next slide. I always like to start any lecture in surgery or topic in surgery with a little bit of anatomy to know where you are, where the discussion is taking place so that you understand what we are talking about. And here, this is the anorectal canal, right? This is the dentate line. Very important for surgeons because above this sense, I'll discuss this later, but just to know that above this, there's no cutaneous nerves, whereas below, right, is where the anal verges. It's got a lot of the sensory nerves, right? And then your circular muscles, we leave that alone, and to show you where your hemorrhoidal plexus, your superior hemorrhoidal plexus are in the upper part of the anal canal. This is what they also call as the surgical anal canal. This is the anal verge. The superior hemorrhoidal plexus are up here, right? Then you get your inferior hemorrhoidal plexus, which again they are situated subcutaneously at the anal verge. Then you have your external sphincter, your pars ligament, and the internal sphincter. Those are just for completion. Right? So what are hemorrhoids? They're actually venous plexuses. They are submucosal cushions. Because as later I'll show you in the slide, we need a sphincter at the bottom end of our rectum, anorectal area, so to be not incontinent, right? The sphincter muscles can do it, but you also need like a tap, not only the metallic part, you need a rubber cushion. So in the same way, here, these venous plexus, the internal venous plexuses act as cushions, so to maintain continence of the anorectal canal, right? So this is your vascular cushion. This is the mucosa. This is a submucosa area with your muscles around. It is anchored by an anchoring tissue or ligament above and is held in place by this pars ligament. So, as a consequence of this venous plexus that I showed you, their downward displacement, right? That is what is the cause for hemorrhoids and bleeding. We will see it now. So what happens is a stretching of this ligament. As it gets more stretched, it comes down, gets bigger, and even the stretching or rupture of the pars ligament occurs, and then it becomes a prolapsed hemorrhoid. So hemorrhoids are venous plexuses. They are anatomical, but once they have a downward displacement in a pathological condition, these submucosal cushions are called hemorrhoids. So this is what it looks like in a normal person. Then when they're stretching, when the pathology trauma takes place, then you get what is hemorrhoids in your you get hemorrhoids. So this is an animation to show you how what hemorrhoids is. You can see that these hemorrhoids, these are the anal cushions, right? And traumatized, they get pushed down, they come down, and then they prolapse and become large, and they protrude outside. What are the types of hemorrhoids, right? There's one, the internal hemorrhoid, which is the true hemorrhoid because they occur above the dentate line. There's no sensory nerve there. Therefore, there's no obvious pain except in pressure, right? And then the external hemorrhoids, they are actually subcutaneous vessels, as you can see here, which get ruptured, and they are called external hemorrhoids. They are very painful because this is skin, and there's a rich nerve supply in this area. Therefore, when you're stretched in that area, you get severe pain. So what are the grades of hemorrhoid? It's nice to know. You just say hemorrhoids, you don't know how bad the hemorrhoid is. So by grading, we have been able to tell you how serious the hemorrhoid is. Grade 1 hemorrhoids are those with anal cushions above the dentate line. They only bleed. That means there's bleeding when you pass motion or toilet paper, you can find blood. They do not prolapse. That means they don't come out. In grade 2, right, they come out. When you pass motion or straining, they will come out. You'll feel some discomfort, you may bleed. But once you pass motion and you have finished the act of defecation, they go back or reduce spontaneously. Then you get the grade 3, right? When you pass motion, it comes out and it remains outside, right? But with the finger, you can push it in and it goes up. Then you get the 4th degree where it comes out, and because it is so large and swollen because it's edematous, you're not able to push it inside. So that's called grade 4. So you got grade 1, grade 2, grade 3, and grade 4. We'll have a look what they are actually. If you look at grade 1, you see the ligaments are all still intact. They're just large here. In grade 2, the pars ligament is intact. This ligament is stretched, so it comes out, and when you finish defecation, it can go back inside. Whereas here, the pars ligament is also stretched, therefore it comes out. It can't go back by itself. You have to push it with your hand and it stays in. Here it is so large, so edematous that it's not possible to push it in. So this is what you see in grade 1. You won't be able to see this. Only the doctor can see with the proctoscope, right? Then grade 2 is this, right? You may feel something inside when you pass motion and then it goes out, goes in by itself. And then you get your grade 3, where it comes out you have to push it in and it stays there. Then you get your grade 4, which you're not able to push in, right? So these are the 4 different grades of hemorrhoids. What are the risk factors? Hereditary, right? And this is the genes passed down to you from your parents. You can't stop it. Just take care, be aware of it, and try to maintain a fairly good lifestyle so that you don't get these hemorrhoids. The other one is in pregnancy, both because of hormonal changes plus the size of the uterus getting bigger and compressing on the vessels, you get plexus of hemorrhoids, and all the others like weightlifting, constipation, toilet habits, when you're basically sitting reading newspaper or playing social media, right? It's training yourself, sedentary, right? Standing too long, carrying heavy things. The other one is those people who don't take enough fiber, so as your stools are not large enough and soft enough to be passed out. Right? And of course, sometimes when you get infection, you get a diarrhea, and that also. So constipation and diarrhea both can cause hemorrhoids. Let's look at what are the symptoms. Symptoms are what the patient presents to the doctor. Pain during bowel movement. Anal pain may just not be due to hemorrhoids alone, right? So there's a proper history taking and an examination to be done, because anal pain can be from so many other causes. And we don't want to miss something more serious and treat it as a hemorrhoid, and when you miss something more serious, right? Pain during bowel movement is one. Bright red stooling and you pass motion in the toilet bowl or in the wipe, right? This again, like pain, there are many other causes for bleeding per rectum, fissure. We are more worried about malignancy and diverticular disease, though all the others are also important to rule out before you treat hemorrhoids. Irritation, itching is because of discharge around the anal region, right? Then the discomfort mainly due to the swelling or the around the anus, right? Sometimes you get one or more lumps because there are 3 hemorrhoids, which can sometimes be painful, or when you touch them, they are very tender. Some people have discharge because the anal cushions are not functioning, therefore the liquid or fluid that's inside the rectum can come out and you get a certain amount of fecal incontinence. The other thing is some people do not know they have hemorrhoids. They come to see the doctor because they're feeling weak, tired, or somebody says you're looking very pale. And these are people who present with anemia, that is low hemoglobin. This is because they are passing blood per rectum in small amounts over a period of time, and therefore they become anemic. So when a patient comes with anemia, one of the things we also check for is to make sure that he has got no hemorrhoids or any other cause of bleeding per rectum that can result in anemia. You may have hemorrhoids. Just listen to this and just have a look. I can't say don't worry, be happy. All I can say is don't worry, don't be shy. 4% of the population seek treatment for hemorrhoids yearly, and in a lifetime, they say 50% of the population will seek treatment for hemorrhoids. So when you see a doctor, what happens? He takes a proper history. As when you say you're bleeding, he will ask you questions about how did you discover the bleeding in the toilet bowl, or when it's mixed with your feces, or is it just a line? So after taking a proper history, he will want to do an examination. He will ask, after doing a general examination, he will ask you to lie down in the couch on the left lateral position. That means your right side is up, your left side is down, you are turned away from him, your knees are bent, your your hips are flexed away so he can examine your perianal area to see whether anything is visible outside. And after having seen there's nothing outside, or if he sees something, he will know what it is. And then he will want to do a rectal examination. He will wear a glove, he will use some jelly, right? And then do a rectal examination. If you experience pain, he will not proceed with the rectal examination. He probably will treat you for that and ask you to come back in a few days' time when the anesthetic effect of the suppository has taken and he's able to put his finger inside. If he's able to put his finger inside, if it is a hemorrhoid, he will not be able to feel the hemorrhoid because only thrombosed hemorrhoids can be felt. If there is no pain, then the doctor will tell you that he's going to do a proctoscopy, which is something like this, right? Where it's lubricated, it's inserted into the rectum, right? And taken out and viewed from here to see. I'll show you pictures of, I showed you an earlier picture of what a first degree hemorrhoid is. That is what you will see. Having finished that, he will tell you what the diagnosis is. If he has not seen any hemorrhoids, or if he has seen hemorrhoid, he will still want you to undergo a flexible sigmoidoscopy if you are in the younger age group, and if you are above 40 or plus, he may suggest to you to do a colonoscopy. Then he will do a blood test to see whether you are anemic. Sometimes we also do a coagulation study to see whether you are bleeding from other causes. And we also want to know your drug history because a lot of people nowadays take aspirin and blood thinners that can cause bleeding easily. So when you're at the age of 40 and above, it is always advisable to go for a health screening and to do a colonoscopy. The indications for colonoscopy I will not go through today because that itself is a separate topic. But if somebody asks me later, I'll be happy to share it with you in a very brief way. And why do we do a colonoscopy? It's because most cancers of the colon begin as polyps. So if you do a colonoscopy, if you see a polyp, you can remove the polyp. So it prevents a polyp from becoming a malignant growth. So that is the idea, and that is the reason why we had advised people to do colonoscopy after the age of 40, right? And I think at regular intervals, depending on what you find every 5 or 10 years. Then once you've made a diagnosis, what are the treatment options, right? There's a non-surgical, surgical open, surgical stapler, and the laser hemorrhoid. This laser hemorrhoid, there are two types of laser hemorrhoid. One is the laser hemorrhoid where the laser, the fiber shoots straight on, and therefore you can burn the mucosa from the outside. This, what we are talking today of submucosal laser ablation, which I will show you later, is a 2 millimeter fiber which fires in a circumferential manner at just 4 millimeters in diameter, so as not to damage other tissue other than what is intended to be. For grade 1 internal hemorrhoid, non-thrombosed, you have to do changes in lifestyle. What are the changes in lifestyle we are talking about? First, have a high fiber diet of fruit, and vegetables, right? 2, drink ample amount of water, right? Don't sit in your chair all whole day, walk about. Keep a proper anal hygiene. and retrain your bad toilet habits. The other thing that we also give patients is some painkillers, either systemic or topical. Topical means around them, inside the anal canal. A short course of topical steroid cream. These usually contain steroid and astringent that will constrict the blood vessels around there, plus xylocaine, which is an analgesic or a painkiller. We also give phlebotomics called Deflon, diazomine, which increases the tone of the vessels and prevents edema and swelling. And the other thing that we also give a stool softener or a laxative. These laxatives, what they do is they increase the bulk of the stool and make it soft, so you are able to pass a large amount of stool softer and easily. For those patients who have got bleeding or up to second-degree hemorrhoids, one of the minor office procedures is rubber band ligation, right? Rubber band ligation is the one that is being shown here is the old method. The newer method is one like this, where this is the gun that is fired. There's a rubber band here. There's a suction device here, so you close, so there's no suction. If these are the hemorrhoids, you put there, when you release, this hemorrhoid is sucked inside this chamber, and when you fire, this gun will release the rubber band like this, and it goes around just like you see in this picture. It constricts the neck of the hemorrhoid, right? Cutting off the blood supply, and in time it will necrose, gangrene, and fall off, leaving a small ulcer around that area. Can be painful. It tends to recur, and sometimes when you do the major ones, the minor hemorrhoids around the area get enlarged. That's what some people say. I got 4 hemorrhoids, 5 hemorrhoids. These are the minor hemorrhoids that get enlarged. Then we have the open hemorrhoidectomy. This is the time-old operation. And then we have the hemorrhoidal artery ligation, which you tie the blood vessel supplying that hemorrhoid. The high rate of recurrence because of that is not popular. There are people who not only tie this, but also tie the rest of the hemorrhoid around and pull the hemorrhoid up. Then we have the stapler hemorrhoidectomy, which is actually a sleeve operation where you remove a donut of tissue around the 4 centimeters, 2 to 4 centimeters from the dentate line. So you pull the whole hemorrhoid back into position, right? And then came the submucosal laser ablation of hemorrhoid, which is the newest in the market, which we have been doing since 2011. We pioneered this in Assunta Hospital, and we have done about more than 500 cases to date. Open hemorrhoidectomy, usually done under anesthesia, either GA or spinal. The patient is lying down and you remove the mucosa, a little bit of the skin, the submucosa, and the hemorrhoidal vessels, plexus inside, right? And at the end of it, the tissue here is being cut. At the end of it, you get this 3. Normally, we say hemorrhoids are at 4, 7, 11, 3, 6, and 12, whatever it is. So the only downside about this is there's an open wound, right? This is a raw area. Sometimes you can see bleeding. It's very painful, right? It's very, very painful. You have to do sitz bath daily. You have to do dressing daily. It's difficult to pass motion because of the raw wound, though you're given laxatives, right? And you can lose up to 2 to 3 weeks of work trying to get this thing to heal. So if you take in terms of cost, the operation may be X dollars, but the time you lost in work is again another X dollars. So when you compare this, it's not actually cheaper. It's probably about the same cost as the other stapler and the laser hemorrhoid. Stapler hemorrhoid is usually done for grade 2 and grade 3 hemorrhoids, and also the reducible grade 4. It's circumferential resection of the mucosa and submucosa. So the whole thing comes out as a ring or a donut, right? This is the gun. This is after you fire. You can see the donut here. Right? That's an animation. I'll show you that afterwards. So you introduce your proctoscope, dilate the anal canal rectum. You put the guard, then you put a stitch around the rectum, 4 centimeters from the dentate line. So you do a bursting suture, so the whole thing becomes encircled and round, right? Okay, now you pull the thing in form, you put the gun inside, you pull the whole thing where the hemorrhoidal tissue comes into this, then you close and you fire, it staples all the way around. So the whole donut tissue around the whole thing has been moved. You must be careful not to get the sphincter muscles. And the other thing is you can also leave the titanium clips are left behind, and must be careful, especially in a female, that you don't take the vaginal wall when you're doing the stapler. Then we have got the submucosal laser ablation hemorrhoid. This is the one that we've been doing now for almost 10 years, and I told you we've done about 500 cases, right? It's actually, the fiber is about 2 millimeters, right? And when you fire the gun, the laser energy is only for 4 millimeters, right? There's a reduction of hemorrhoidal tissue. There's no total destruction. The anoderm is preserved, and there's a reconstruction of the normal anatomical structure. This is a German product, right? This is an animation. This is the hemorrhoid getting enlarged, right? And how you put your proctoscope, tubular endoscope, and then use a laser fiber to burn, right? And then it shrinks immediately, right? About 40% reduces immediately. The anoderm is intact. The sphincter is not affected, and there's no foreign body left inside the body. This is a case that we did in the earlier days. As you can see here, this is the junction. We have made a small incision about 1 to 2 millimeters. This is the laser probe that goes inside. Right, and switch on the light, switch off the light. You can see that the laser fiber has got a light at the top to guide you. Right. What I also do is, after having done this, I put my finger in to guide me so that I'm not too close to the mucosa, and I know how far I am from the muscles. So you basically a very safe guided procedure. You're just shrinking all the blood vessels without affecting the muscle and the mucosa. This is one of the earlier cases. Again, this is before surgery, and this is after surgery, right? So what are the benefits of submucosal laser ablation of hemorrhoid? So why laser? Minimal or no pain. When it comes to pain, all the other surgeries, the pain score is about 7, 8, 9, or 10. The stapler is about 5, 6, 7. When you do submucosal laser ablation, it's about 1, 2, 3. Some of them say, I don't even feel, I just feel a sting around the area and I'm able to pass motion. Very short hospitalization, 1 night minimum. I sometimes tend to keep them for another day to give the antibiotics. They feel normal almost the next day. They're able to pass motion. There's no wound to take care of, right? You can pass motion usually without pain, right? It's not a blind procedure, right? There's preservation of continence, no sphincter muscle damage. The inoderm and the mucous membrane are still intact. Thank you for your patience and your listening to this lecture at lunchtime. I will try to answer as many questions as possible that you put up, or there's anything, or otherwise you can always put up in the Facebook and I will answer. Thank you very much.
So much, Mr. Jeya, for the very interesting talk on this hemorrhoids. Right, I see there are several questions already up on our Facebook comments. So let's dive right into the questions, shall we, Mr. Jeya?
Please.
Okay, so the first one we have there is from Mr. Chan. Can hemorrhoids develop into cancer?
Hemorrhoids don't develop into cancer, definitely not. Yes, definitely not. Hemorrhoids don't develop into cancer.
So that is a short and nice answer, which is no.
Yeah.
All right. So from Miss Lilin. Hi, doctor. If I have hemorrhoids due to hereditary reasons, will the hemorrhoids recur after surgery?
A lot of people ask me this question. There's nothing to stop it from coming back. You have to take care of it, right? I said the lifestyle changes. One of the things I always tell my patients is, you're driving a car, you get a puncture, you repair your puncture, right? Will I get another? If you drive your car carefully, not in some in good roads, I don't think you'll get a puncture. So similarly, lifestyle changes have to take place after surgery, right? And the beautiful thing about laser hemorrhoidectomy is that it's pain-free compared to what people have this notion that hemorrhoidectomy is a painful procedure. So a lot of my patients have been fairly happy with the outcome. So some of them who have had recurrence have come back willingly and saying that I think I've had about 4 cases of recurrence in the last 9 years or 10 years. Sometimes I tell my patients, sometimes maybe the recurrence don't come back to me, go somewhere else. But that's part of the story.
So generally, recurrence is possible, but if you do take care of it, so it's less likely.
Yeah.
All right. So we have one question from Rachel. Hi, Dr. Jeya. What is the pain score for laser treatment?
Okay, I told you the pain score, 1 is minimum, 10 is maximum. Laser hemorrhoid is between 1 to maximum 3, right? Compared to your conventional surgery, which used to be about 8, 9, 10. And your stapler is about 5, 6, 7. So this is definitely a much less painful procedure.
So before we go on with the next question, so if you have still more questions, please feel free to type them into the comment box and we will try our best to answer them. All right, so I shall go on to some of our questions that we received from Google Form. All right, I have one question here. It says blood in stool once in a while. Is it dangerous?
It's not dangerous, but you must get it assured. You must be reassured that where this bleeding is coming from. Because even 𝐶H colon or rectum, what happens is the patients bleed for some time and they stop. They bleed and they stop, right? Sometimes they take treatment, right, at the early stages. So if you are bleeding, please go and see a doctor, please.
So the general answer will be to seek diagnosis. All right,
yes.
get it checked and get to the bottom of what is the reason of the bleeding.
Right.
So one more question from Google before we come back to Facebook. Which stage of the hemorrhoid requires surgery actually?
Which stage of the
hemorrhoid?
Okay, if you do stage 1, you don't do surgery, right? From stage 2 to stage 4, depending on the patient. Now, if you are somebody who is flying around business, going around the world, or you live in a place where you have no access to medical treatment, or if you're a logger working in a far out post, even stage 2, you may not want to take a chance and wait, right? You may want to get something done before you go back there. Of course, stage 4, you've got no choice, right? I always like to tell the story that I always get an angpao for Chinese New Year, 2 or 3 cases. 2-3 days before Chinese New Year, patients will come and stand. When I ask them to sit, they will not sit. They say, "Can't sit, doctor." So I say, "Why?" And they say they've got thrombosed hemorrhoids. So I tell them, "Thank God you came 3 days before you're going back for your reunion dinner. If you get admitted, we'll do something and you may be able to still go for reunion." So 4th stage, you definitely require. I think at 3rd stage, you can try some treatment, but eventually you will succumb to it once you stop your medical treatment.
All right, let's get back to our Facebook question. I have one here. Yes, from Amalina Ghazali. Dr. Jeya, do you mean stapler is not suitable for female? How about laser? May I know the recovery time after laser treatment?
I didn't say stapler is not suitable for female. In every surgery, you have to take care, right? Whether you're doing stapler, whether you're doing laser, whether you're doing open, or whether you're doing laparotomy for anything, you always have to take care. You must know what are the complications that can happen. So stapler is suitable for female, right? How about laser? Yes, it is less traumatic than stapler, right? And the recovery time, I've had patients who go back from almost the next day, they feel better to go back, right? So it all again varies from person to person. There are people who feel better the next day, and there are people who say, "I feel uncomfortable even after 2 weeks," right? I sometimes feel it is because whether you're self-employed or you're working for somebody.
So, Ms. Amalina, stapler surgery is definitely safe and suitable for female, and the recovery time is relatively quick. So we'll move on to the next question. I think this is very important.
Somebody said, is this procedure
approved by insurance?
Yeah, this procedure is actually approved by insurance, right? Though we get questioned why we are doing laser, it is approved. We have got a letter from the ministry to say that it's approved, and in fact, most of the patients that we do are insurance patients, right? The surgical cost, whether I do open or I do laser or open hemorrhoidectomy, what the doctor gets is the same, or maybe 15% more, I don't know, recently, but otherwise it's the same. It's covered by insurance, and the extra money that goes for the laser or for the stapler, right, the extra 3,000, if you look back at the number of days you're going to lose work, 3 weeks of no work, right, I think it's a better choice.
All right, so move on to one more question here. It says, it's from Chong. So, hi, Dr. Jeya. What is the post-operation care after laser surgery?
Right. You go after, say you get discharged at 24 or 48 hours after surgery for laser. You go back, you continue with your treatment, tablets for deaf lung. I give them. If the patient has felt pain while being in the ward, I give them some paracetamol to take. I give them a laxative for about a week and ask them to monitor if they are able to pass motion, don't take. right? And just to keep the perineum clean, because there's a three small incisions that have been made around the perianal area. That's about all. And of course, change your lifestyle.
Yeah, so lifestyle is
most important.
Very important. Yeah, most important. All right, I have one more question actually from Google. All right, it's rather long, but I'll mention it. What are the general guidelines or good practices to minimize the risk of contracting hemorrhoids? I'm sure part of the answer has been given by Mr. Jeya earlier.
I think basically, as I told you, change of lifestyle. That's the basic thing. People don't eat enough fiber. A lot of children, especially, don't eat enough vegetables, right? Fruits. We become a very highly meat-eating nation or people. Cut down on your meat. Eat more vegetables, more fiber, things with fiber. Drink enough water. I think a good example to see all our Assunta nurses walking around every day when they come to work. I see all of them carrying a bottle of water. I think it's a very good habit for them to drink that amount of water, right? Do some light exercises and don't strain. Don't go to the toilet and force yourself to pass motion. When you're ready to pass motion, go to the toilet, right? If it's not coming well, then come and see a doctor and seek advice, because you may not be able to pass motion for so many other medical reasons, right? Maybe something wrong with your thyroid function, etc. So seek help. It's available. Knowledge is available. Do that. Thank you.
All right. So one more question actually from myself. All right. Many years ago, I do heard about this. I'm not sure if it's a myth or it's a reality. So what happened is that people say do not sit on seats that has been previously warmed by another person.
Usually that's because of the warmth. That's why we tell you not to sit too long in the office. Because if you sit too long in the office, it's a belief, I don't know whether scientifically proven, increase in warmth increases circulation.
Yes.
Right?
Yes.
And you're sitting together. So you're not moving, therefore is all the blood gravitating down. That's the belief I think people believe in. But how far it's true, since people who do sedentary jobs tend to get it, people who are office jobs tend to get it more than people who are not that kind of work. Maybe it holds water.
But it's not exactly true that we will contract this hemorrhoids from another person.
You don't contract hemorrhoids. You get hemorrhoid. Contract means it's like
it's passed from another person.
Yeah.
All right. I believe that's all the time we have for questions today. Thank you for keeping the questions coming. And if we have not yet answered your questions, we will seek to answer them by replying to your comments. So, we have reached the end of our session today. Thank you once again to our speaker, Mr. Jeya, for the very informative talk and in-depth look into hemorrhoids and the modalities of treatment, especially laser treatment. So thank you all for staying with us today throughout this session, and I hope you have benefited from this talk as much as I do.
Thanks for sharing the meeting. Thanks to all of you for listening, spending your time during lunchtime. I also would like to thank the Assunta Hospital for providing the platform, and especially to Carmen from marketing for organizing this, and Bella from WSM and all the staff for making the slide and making this talk possible. Have a good day. If you have any questions, please post. We'll try to answer them.
All right. So stay safe, everyone, and please join us for our next live talk on the topic, the role of minimally invasive surgery in gynecology, by our consultant ONG, Dr. Kuharaj. Take care and bye-bye.
Thank you.